you can read this particular task, and you know the information gathering now. She only has got a breathlessness, and she has been diagnosed as a WHO class 2 heart disease. Okay, so we can have a 6 minutes station, and then we can proceed with the next one. If you want to go ahead, you can go ahead.
Okay,
Hello.
sir.
Yeah, 1 minute I'll give you. Okay, everything is normal. She only has got a breathlessness. Okay, I'll put the time.
Okay, sir. That was your question, Emily. So, I will take you about your pregnancy journey. I also concern your consent. Now you see that you have the breathlessness on the walking, and then when we do the ultrasound of your heart, that is a sign abnormality as you. That is in our heart. There are the four chambers and also the four valves in you. One of the valves is narrowed. You have the breathlessness while you're walking. If that's the I mean that if that condition is severe, you may need the valve replacement in the future. For now, I will refer you to the heart doctor
Yeah,
for the special.
doctor,
Yes,
I
yes,
have a
Emily.
query. Yeah. About this breathlessness, will it become worse, doctor, as my pregnancy advances?
Yes, if the pregnancy appears, yeah, sometimes your breathlessness may be more and more severe, but we need to control it with the input of your heart doctor. So now urgently, I need to refer you to the heart doctor for her opinions, and also you also need to care under the heart doctor. Okay.
Yes, doctor. Okay, doctor. Okay. And what will be the course of my pregnancy, doctor?
For that heart problem, you may have the during the pregnancy, you may have the increased heart rate and the shortness of breath. Now you have him, you have already have, and then there is also the black clot formation, also there is also effect of the infection on your heart, and also increase cesarean section. I mean your baby born from your wall, I mean from your abdomen, and then increase bleeding after the delivery. For your baby, there is also side effect on your baby, like the baby may grow small, and the baby may deliver earlier than the due date, and then now also the baby die inside your womb. Emily, I don't want to score you, but just trying to warn you to know the facts that you are having. Do you have any question, Emily?
Doctor, what about my medications, doctor? I'm taking bisoprolol tablet, folic acid tablet. So, should I continue with them, same tablet, or
Now,
do I need to
again,
change?
then what? Folic acid, and another thing is what are you taking?
And bisoprolols, doctor, bisoprolol I'm taking.
Oh, for that medication, I need to refer you to the heart doctor so that he will review your medications, and then he will say he will adjust your dose as well as the and then adjust your dose. Then and also yes.
Yeah.
Now I will tell you about your pregnancy journey. Okay.
Yes, doctor. And regarding delivery, you said I'll need a cesarean section. I'm really afraid of cesarean section, doctor. I want to go ahead. I want to keep my labor process normal, doctor. Is it possible?
Yes, it is possible. Emily, but we need to decide. We usually for the heart disease patient, we usually aim for the normal delivery, unless there is any indication for the cesarean section. And also for the normal delivery, we will monitor very closely your vital signs. I mean that your blood pressure, heart rate, and also your breathing rate, and also your intake output, and then baby, and then if there is any prolonged labor, at that time we will consider to do the instrumental delivery. But you have the risk of the increased bleeding after the delivery, so we will take care of this. We will do all of the preventive measure, and then if need the bed, we will avoid the starting medications, what we call the argometry. And then, do you have any other question, Emily?
Doctor, will my baby be fine, or there is some risk to the baby, doctor?
Yes. Baby, there is a risk of the baby grow small. So I will offer you the cereal growth during your pregnancy, and also we also do the same head to toe scan from now, and then to shed also do the feeder heart scan to know that your baby also has the heart problem or not. I will also offer you like that scan, and then if it is to deliver you at 10. Do you have any other question, Emily?
Doctor, will I be able to breastfeed, doctor?
Yes, Emily. After the delivery, we encourage you to do the breastfeeding, and
Yes,
also
time is up now. Time is up. Actually, I gave 6 minutes only, but actually 6 minutes means 4 minutes you have to eat. Is assume that 4 minutes information gathering will be over. Okay, so overall, your performance was quite okay. That you are developing a rapport with the role player. That is one of the good thing. Okay, but certain things which I noticed, doctor, is there are certain medical jargon. Especially yesterday you said when you started that I understand that your GP has referred you with you have a heart problem. Okay, so so you have a cardiac problem. Okay, not the heart problem. It's, yeah, these things happen unknowingly. So when you now what you can do, when you are reading the task, primarily when you are reading the task in 2 minutes, try to understand which are the words which you need to avoid. Okay, so that is one of the practice. You can note down these points. I will send my video also to you, so you listen to this video again and note down these points and try to improve upon it. Otherwise your presentation is good, your clinical knowledge is very good, doctor. The only thing is that if you present in a proper way, definitely you will pass. Okay, so regarding one more thing in today's presentation, what I noticed, doctor, is when you started talking with the role player and explaining the condition and all, it was good that you said that there are 4 chambers, there are valves and all, but you did not allow the role player to speak initially. I had to, interrupt you. Okay, after that you always do you have any question, do you have any question, so just maintain that particular flow in any task. When you are doing performing any type of task, maintain that particular thing, that always ask whether the role player is understanding or not. Okay, or does she have any query. Okay, so these were the only situations. And in maternal medicine, be aware that last consultants follow up, then the medication which she is taking, we have to talk on that, whether they are safe, whether they are not safe. Okay, regarding bisoprolol, it is safe. It is not to be worried about it. Even if you say that I'll discuss with the consultant or I'll refer it to the consultant, that is a safety measure, but otherwise it is a safe medication. And this folic acid is you have mentioned. Okay, so I think overall this performance was good. So I'll just cover the key of this particular task. Okay, so let's go
Okay.
to Yeah, let's discuss together. Now, in key points, we need to clarify the symptoms in the information gathering: breathlessness, chest pain, palpitations, syncope, orthopnea, uh, uh, PND, fatigue, etc. This you have asked. Okay, past cardiac history, diagnosis, interventions, arrhythmias, hospitalization, etc. Previous ECG results and severity classification, functional status regarding the grading you can explain. Okay, let us see the task. Here they have mentioned about the moderate mitral stenosis. Now they have mentioned the moderate minor mitral stenosis. Then in your clinical knowledge you should mention that we grade this particular condition depending upon severity, and I feel you are somewhere in the grade 2 or grade 3. Okay, so this patient is actually in grade 2 only. Okay, when we are dealing with a mitral valve, anticoagulation history is very important. So that particular word should come. Are you on any blood thinner, or has the doctor spoken to you regarding any blood thinner? Okay, so rest of the things were quite okay in the history. Okay, then yes, you should be able to recognize that she is in a WHO class 2 or class 3, that is moderately increased maternal risk. Immediate referral to cardiology MDT that you have mentioned. Okay, the MDT constitutes obstetricians, cardiologists, anesthetists, specialists, midwife, etc. This bisoprolol is to be continued. It is safe in pregnancy but requires growth monitoring. Okay, that also you have covered. Okay, high dose folic acid until 12 weeks in the future pregnancies, safe multivitamins now. Education warning symptoms, worsening breathlessness. Yes. Always remember red flag symptoms. Okay. Especially while closing the task, even if everything is fine, you always give the red flag. Okay. So that here worsening breathlessness, chest pain, palpitation, urgent evaluation. The need for thromboprophylaxis assessment if atrial fibrillation develops. Ensure delivery. Yes, one more thing that you mentioned about the cesarean section. That time, the other role player, my perception was that, doctor, I'm not sure whether it is your mic which is echoing or my mic which is echoing. Can you unmute yourself, doctor? Uh, Okay, yeah, yeah. Now, when you mentioned about the cesarean section, my perception was that you were talking that I have to undergo cesarean section. That was my perception. In heart disease, any condition where there is no direct indication for cesarean section, we have to mention not a direct indication or does not require cesarean section in all cases. Only when the labor process is difficult or we find any issue with you or your baby, then we will consider. This particular thing is very, they want you that why you are doing a cesarean section and you are not doing this patient primarily for cesarean section. Is that right? Are you getting it? So your wording should be like that. So then I ask you that, doctor, I'm afraid of surgery. I want to keep the process as normal. So this is a clue by the role player to you to check whether you are coming back to the track or not. By case not come to the track, then the patient will go in a different way. Okay, is that right? Is it clear to you or not clear? Clear?
Sir, the line is broken down.
Uh, just a moment. I'll check any issue at my end. Hello, can you hear me?
Yes, Anna.
Yeah. See, this cesarean section, when you mentioned about the cesarean section, my perception was that because I have a heart disease, I will have to undergo cesarean section. Okay. But in heart disease, it is not a direct indication for cesarean section. Okay. So our wording should be that you can have a normal labor or you can have a process of childbirth as normal as possible or as natural as possible. However, cesarean section may be required if there is any issue with the baby or in your health. But otherwise, we can try normal process of childbirth for you. Okay, so that is what they are expecting, that you are not directly giving us indication like a decision for cesarean section. Okay, so that is the most important thing, and most of the conditions do not require. Okay, direct. So that was the one thing. So we'll go ahead with the further task. Then need for thromboprophylaxis, ensure planning in a tertiary care institute, HDU, etc. Avoid fluid overload in labor and postpartum. Okay, so during the process of labor, we'll restrict the amount of fluid which we are going to give to you. Okay, communication with the patient, good performance includes using clear and non-technical language. Now these particular sentences you can just keep in mind. Your heart wall is narrower than normal, so your heart has to work harder during the pregnancy. As the pregnancy progresses, blood volume increases, so symptoms can worsen. And you have to reassure, but you will not give any false hope. With the close specialist care, most women in your situation have a good outcome, but you are at a higher risk of complications. And this is not to scare you. You have used this particular word that was very good. Okay. Then we will address her concerns, that what is the risk to the mother, breathlessness, arrhythmia, heart failure, etc. can happen. Risk to the baby, growth restrictions, preterm birth, mitigated with close monitoring. Then mode of delivery, vaginal is possible unless obstetric or cardiac indication for LSCs. Breastfeeding usually safe. So we have to reach up to the breastfeeding. Okay. And if possible, some contraception also. That is actually the closing of maternal medicine station. Are you getting it, doctor?
Yes, teacher.
So we have to go to the postpartum period. Okay, means antenatal, intrapartum, and postpartum. All these three we are going to cover. Then communication with the colleague. Refer to MDT, cardiology, anesthesia, specialist midwife, possibly obstetric physician, etc. Share key history, echo results, functional status, and medication. Arrange joint antenatal clinic review. Document discussions and care plan in notes. Liaise with the neonatal team if preterm birth is likely. Okay. That clinical knowledge, candidates should demonstrate understanding of physiological effects in pregnancy and effect on maternal statuses. Risk classification, this is WHO 2 or 3. Monitoring frequent until visits will be required. We will be doing the growth scans, echocardiogram in the mid pregnancy. That all you have mentioned. Then coming to the labor management, vaginal delivery with shortened second stage, regional anesthesia with careful fluid balance, avoid tachycardia, sudden BP changes, and postnatally monitor for pulmonary edema. Risk is highest in the first 24 to 72 hours postpartum. Okay, this is what we need to avoid. So this is the same thing what we have discussed. I have tabulated so that when you are revising, no, it will help you. Okay, the same thing. So should we go ahead with the next task, doctor?
Sir, for the contraception in the cardiac disease, COC uh, uh, is safe or not?
COC, I think it is a UK MEC too. I'll check about the contraception. I'll post in the group. Okay, I'll post this contraception aspect in the group. Okay, but
Okay,
what
sir.
I remember is especially the POPs are the safer ones. Okay, so
Okay.
that is one of the thing. I'll post in the group. Okay,
Okay,
so
sir.
let's go ahead with the next task,
Okay, sir.
and your time starts.
Okay, sir. Is there any other slide, sir?
No, no.
Okay.
Time is up, doctor.
I'm one of the doctors in the clinic today. May I confirm your name and age, please?
Doctor, I am Sarah Bennett. My age is 30 years, doctor.
It is okay if I call you Sarah.
Yes, doctor, that's fine, doctor.
Okay, Sarah. I understand that you are here today because you are now in the dry pregnant and then you have the SLE disease. Am I right?
Yes, doctor. Yes. I have just completed my third month, and I have a condition called that SLE, which was diagnosed, I think, maybe 6, 7 years back when I was around 23 years. But I think it is stable now because my specialist also told me that I am in a good condition now and I can conceive also. And currently I'm taking some tablets for the same. So I just wanted to know, doctor, and I'm little worried also whether there'll be any risk to my baby. Can you please guide me this?
Okay. May I know the medication name that you are taking now?
Yes, doctor. Actually, I think one drug called as HCQ, that is hydroxychloroquine, I think, and one steroid tablet is there, which I'm taking daily, and aspirin tablet is started by my GP. So these are the tablets which I am taking.
So you are now taking the hydroxychloroquine and the aspirin, right?
Yes, yes, doctor. Yes, and one steroid tablet, doctor.
Okay. And then, now, could you tell me more about your current pregnancy? It is your first pregnancy?
Yeah, yes, doctor. This is actually my second pregnancy. I had one miscarriage also, and but it this particular pregnancy was very well planned, and my specialist also told me that my lupus is under control, and I can go ahead with the pregnancy now. And luckily, we got good results. So that is the thing. And initially, I had a little bit of nausea, but now everything is under control, doctor.
Okay. So have you already taken the folic acid?
Yes, doctor. I'm taking the folic acid now.
How about the dose?
I think some 5 milligram my GP has suggested. Yeah.
Okay. So how about your disease control of your SLE? It is very well controlled, right?
Yes, actually, currently I don't have much symptoms. Occasionally joint pain, but that I can manage with the same
Okay.
tablet.
So is there any problem in your kidney function?
No, doctor. Initially, I did had some, the kidney function was not good, but now everything is under control, doctor.
Okay.
Pardon me, doctor.
What was your last flare? I mean that your SLE life-threatening condition?
It is diagnosed around 6 to 7 years back, and I had joint pain that time, and there was some problem with the kidney also. And the drug, I think some medication was started called mycophenolate and all, but later on, doctor told me that we will change this because I was planning the pregnancy. Yeah.
Okay. So have you already stopped that mycophenolate 3 months ago, right?
Yes, yes, long back, doctor.
Okay. So have you already done any test for the special protein?
Yes, yes, doctor. Some test was positive. I guess some antibody is positive for SLE, they said. That is what I remember, doctor.
Okay, no problem. I will check with your permission. I will check your notes.
Yeah.
Okay. Apart from the SLE, do you have any other medical problem?
No, doctor. No,
Okay. Do you have any previous surgery on your tummy or the down below?
no, no, no.
Do you have any drug allergy?
No, doctor.
Okay. So do you have any other? Sorry, do you smoke, drink alcohol, or pardon me asking you any recreational drug?
No, doctor. No.
Blood group?
My blood group is A positive, doctor.
Do you have any rejection for the blood transfusion?
No, no. No.
Okay. So how about your support at home?
Yeah, my partner is very good and supportive.
Okay, thanks for sharing information, Sarah. I would like to examine you in the presence of the chaperone. With your permission, I would like to check your the general condition as well as your tummy. It is okay?
Yes, doctor. That's fine, doctor.
Okay. Now, what do you know about your SLE on your pregnancy?
Actually, I don't know much. I'm really worried what will happen to the baby, doctor. Can you please guide me regarding this, doctor?
Okay, for the SLE, as you know, our own defense system to attack our own body tissue. That is like the skin, joints, and also the internal organ. And also, if you are the work through during the pregnancy, you have the healthy baby, and then also you have the healthy pregnancy. If you are not in control, there are the side effect on your baby as well as you. So for you, there are the increased chance of the there are the increased chance of the increased blood pressure and the protein in the urine, increased blood sugar level, as well as the and also the increased bleeding after the delivery. These are the effects for the baby. There are the effects like the baby may grow small, and then baby can deliver earlier than the due date, and also baby can have the heart block, and also baby can die inside your womb. Sarah, I don't want to scare you, but I just want to know the first thing that you need to know. Okay, Sarah, do you have any other question?
Doctor, so my baby will also be at risk because of this lupus, you mean to say, doctor?
Uh, yes, now you are the well control, and then you are now in the safe hands. That means we group of the doctors, including my consultant, your SLE doctor, your GP, as well as the baby doctor, pain doctor will take care of you. So don't be so worried about that, Sarah. So let me explain you about your pregnancy journey, okay?
Yeah, yeah. But what about my baby? Will baby also develop this lupus, doctor?
For the baby, syndrome, baby can have, but we need to check. I need to review your notes, which antibodies and you have. If you have the antibody like the anti-ro or the anti-lad, your baby has the risk of the heart block at the time. So we will offer you to do the D-Day heart scan from the 16 week, weekly, and then we will also offer you to do the head to toe scan from the 18 to the 20 weeks to check how your baby is growing, and then as you has the risk of the black clot formations, so we will offer you the aspirin from the 12 weeks of now. I will offer you the aspirin, and also I will also offer you the blood thinning agent from the 28 weeks of your pregnancy up to you need to take that blood thinning agent up to the 6 weeks after the delivery. So do you have any other question, Sarah? Are you
What,
following me?
yeah, yeah. What about my delivery, doctor? What kind of delivery I'll have?
Okay, for the delivery, we usually aim for the normal delivery, and then if you are the work control, we need to deliver. We will deliver at the time, and then you need to deliver at the specialized center, who has the your when your SIE available, and then and also we during the delivery, now you are taking the steroid, so we will give you the medication, what we call the hydrocortisone injection, to decrease your steroid stress. And also during the delivery, we will monitor your fluid intake and output, and also we will monitor you very closely. And then your baby will also be monitored by the machines continuously. And then after the delivery, the baby will take care by the baby doctor, and then we encourage you early mobilizations and also the breastfeeding. And then we will offer you the safe and acceptable contraception, but you need to avoid the combined pay because it increase the blood clot formation. Are you with me, Sarah? Do you have any question?
No, doctor. That was the thing which I wanted to know. Yeah, your time is up.
Okay,
Time is
okay,
up.
sir.
Yeah. This was very well performed station. Very good station you have done. Okay. Only thing is that at a couple of places, like when we are discussing about this SLE or lupus, think about one joint pain. Okay. And think about renal problems. Okay. And because of this SLE, she will definitely at high risk for the development of the FGR. Okay, superimposed preeclampsia, and also about the gestational diabetes mellitus. Okay, because she's on steroids. She's taking steroids. So that screening, gestational diabetes mellitus screening, did you tell me? I think this was missed. This is what I felt. And in the information gathering, family history was missed. Means you did not ask. You covered all the template, but is there any significant family history of any disease in your family? That was missing. Okay. So, but overall template you have covered very well, and you have taken care of all the aspects. Okay. Only thing is that I wanted we talk about positive and negative history pertaining to the that particular medical condition. Say if it is epilepsy, then when was the last episode, when was the last visit, and all. Something with lupus, we will have to ask about the renal parameter also, and we will have to ask about this joint pain also. Okay, and in the MDT, we will have to refer to rheumatologist and kidney specialist also. Okay, and here role player volunteered that she was on mycophenolate. That means there was a transient renal issue. Okay, lupus nephritis was there, and that lupus nephritis came under control, and she was in a young and reproductive age group. That is why she has been shifted to the this HCQ only. Okay, so those were the significant findings, and role player definitely help you, but we should be able to focus, considering the diagnosis of that particular condition, what are the symptoms which we will be asking. Okay, positive and negative. Okay, we'll just run through this now, this slide.
Sir,
Okay. Yeah,
yeah, for the SLE case, can like this,
uh, uh, I
medical
couldn't.
charcoal or not?
No, say lupus. They call it as a lupus. Rather than SLE, they call it as a lupus. Lupus. This condition, the patient calls it as a lupus. Lupus.
No, I miss SLE flare.
Flare. Flare is
Yes,
flare. Flare is lupus is flaring. Flare is acceptable word. Flare.
flare is also the medical charcoal.
No, 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 no. Okay.
Yes.
So we'll go through the keys. Okay. So SLE, when it was diagnosed, what were the manifestations? What kind? As I told you, whether she had any renal, CNS, skin, joints. We should never miss the kidney and joints. We should never miss, and skin also. Okay. Then organ involvement will need to ask. Disease activity, recent flares, symptoms suggestive of flare, medication history, current drugs that you have definitely asked. Your first question was regarding the medication. Okay. So past immunosuppressants, teratogenic exposures, like in this case, there was a history of bisphosphonates, but it was stopped long back. Okay. Then autoantibody status, anti-Rho, anti-La, anti-phospholipid antibodies, renal history, lupus nephritis, proteinuria, creatinine baseline, obstetric history, miscarriages, preeclampsia, IUGR, preterm birth, comorbidities, hypertension, diabetes, thyroid disease, and allergies, social factors, support network. I just don't remember whether did you ask allergy here in this case today's. I remember yesterday you asked, but I'm not sure today here you ask or not. Okay. Then patient safety measures, recognize that the pregnancy is well controlled. SLE has got a good prognosis, but it is a high risk. So this is very important. When your SLE is well good control, no, your outcome is good. Okay. So that we need to emphasize. This is very specific in this case because she is stable since last 3 to 4 years. She is having lupus since last 7 years, but the condition is stable since last 3 4 years. And if the condition is stable for more than 6 months, then the chances of relapse are also less, and pregnancy is likely to run a smooth course. Okay, so these were the reassuring words which we should mention in the. Okay. Then anti-Rho, anti-La positive. Monitor the fetus for congenital heart block. Fetal echo at 18 to 20 weeks, and we will have to repeat maybe around 28 to 32 weeks of gestation. Then close BP monitoring, urine monitoring to detect preeclampsia. Okay, so these particular two things we need to mention. Then communication with the patient about jargon. Lupus. So always use the word lupus. Lupus is a condition where your immune system is overactive, and pregnancy changes can sometimes make it flare. Okay, balance risk and reassurance. Because of lupus is quite quiet now, your chance of a healthy pregnancy is much better, but we will watch you more closely. Okay, so reassurance is very important. Then express specific risk like flare risk, especially if recent active disease, preeclampsia, IUGR, preterm birth, neonatal lupus, and congenital heart block risk from anti-Rho, anti-La. Okay. Then outline monitoring. Like a frequent antenatal visits, growth scan every 4 weeks from 24 week onwards, fetal echo if anti-Rho, anti-La is positive, medication, continue safe drugs, avoid stopping suddenly, can lead to flare, labor and delivery, vaginal birth is possible unless obstetric indication for cesarean section, and early anesthetic review. If she is on high dose of steroids, then we need to. This is one of the important thing. In the referral to the colleague, anesthesia referral is very important because they have to give the rescue dose. Okay, and that I think you mentioned will give it the convert it during the time of delivery. You mentioned, is that right?
Yes, sir.
Yeah. So that point is very important. Then breastfeeding, again, hydroxychloroquine is very safe, and low dose prednisone can also be continued. Then communication with colleagues. I think there is little echoing. I'll just. Okay, communication with the colleague, referral to the maternal medicine, obstetrician, anesthetist, fetal medicine. Okay. Share baseline disease status, antibody profile, renal function. Agree written care plan. Inform GP and community midwife for shared care. Liaise with the neonatal team regarding monitoring of lupus. Okay. So these are the referrals you should do in this particular case. Then applied clinical knowledge was quite good. This part you should emphasize. The outcome is best when the disease is present for more than 6 months before pregnancy. If you do not have flare in last 6 months before the pregnancy will run a smooth course. Okay. Then medication safety we have discussed. Unsafe medication, we had discussion about it. Mycophenolate she has stopped. Other drugs are also unsafe. Then anti-Rho, anti-La body can lead to neonatal lupus and congenital heart block in around 2% of cases. Okay. Antiphospholipid antibody can lead to risk of miscarriage, and that will require aspirin plus heparin. But in this case, you mentioned that I would like to go through the notes. Okay, so that was a right point. Which antibodies are positive in her case that you tried to identify. Okay, she had only anti-Rho and anti-La, and antiphospholipid was negative. Okay, so that was the thing. Then delivery plan timing based on the maternal and fetal condition. Avoid prolonged second stage if severe organ disease. Monitor for flare, adjust steroids if needed, and ensure a safe breastfeeding medications. So same thing I have communicated, mentioned here. Okay, so task we have covered. We'll start with the next task. Okay, that is
Okay,
also
sir.
role player station. Okay,
Okay, sir.
so this is the next task. Your time starts now. Okay. This is the second slide.
Okay, sir.
The birth weight is 4.2 instead of 3.7. It is 4.2.
Sorry.
Birth weight, expected birth weight is 4.2, 97th percentile, 4.2 at 36 weeks and 4 days. Here there is a correction. Here there is a correction.
Okay.
Your time is up.
Hello, I'm Dr. A. I'm one of the doctors in the clinic today. May I confirm your name, age, please?
Doctor, I am Anita Sharma. My age is 32, doctor.
How can I call you?
You can call me Anita, doctor.
Anita, I understand that you are here today because you are now in the 36th week pregnancy, and you also have the type 2 diabetes mellitus. Am I right?
Yes, doctor. Actually, since last 3 years, I have been diagnosed, and I am taking insulin also. I am taking some tablet metformin also. Doctor, now throughout the pregnancy, I have gone through many tests and all, so I'm really worried about my delivery. So can you please guide me regarding the same?
Okay, I will address all of your concerns in a few minutes. It is okay?
Yeah, doctor, that's fine.
Okay, Anita, how about your diabetes control during the pregnancy?
Actually, this insulin is added during the pregnancy. Initially, I was only on tablets, but I think maybe around 4th month and 5th month onwards, the insulin is added. But my sugars I maintained very well. I was very particular with medications and injections also, and that was quite good, doctor.
Okay, your lab visits with your diabetes doctor?
I visit him every 15 days. When I come for my clinic here, I have an appointment at the same time, doctor.
Okay, how about have you already done the growth scans, right?
Yeah, but this last scan, the sonologist told me something that I need to discuss. I'm worried about that also, doctor.
Okay, and then this is your first pregnancy?
No, doctor, this is my second pregnancy. First pregnancy also I had diabetes. That was only during the pregnancy. After that, it came back to normal. But maybe after that again, I started having sugars.
Okay, so how about your baby bell weight and for your first pregnancy?
It was a 3.2 or 3.3 kg, something like that. Your voice is not clear. You are not audible.
Oh,
Yeah. Now it is okay. Yeah.
yes. How the baby born?
Yeah. It was a vaginal delivery, doctor. Normal delivery. Yeah.
Is there any problem during the delivery?
No. Baby was fine, doctor.
Okay. Do you have any other medical problem apart from that diabetes mellitus?
No.
Okay. Do you have any previous surgery on your tummy or the down below?
No.
Do you have any drug allergy?
No, doctor.
Do you smoke, drink alcohol, or pardon me asking you any recreational drug?
No, not at all.
Okay. And then do you use and then how about your BMI? How about your weight to height ratio?
It's 31, doctor.
Okay. And then how about your blood group?
It's A positive, doctor.
Do you have any drug allergy?
No.
Do you have any rejection for blood transfusion?
No.
So how about your support at home?
My partner is very good, supportive, doctor.
Okay. During this pregnancy, do you have any other medication apart from the metformin and the insulin?
Doctor, I was given folic acid that I continued, and nothing else I required.
Sorry.
Only folic acid I continued, doctor, and these
Okay.
injections and tablet for the sugar. That's all.
Okay. Okay. Now, thanks for sharing information, Anita. Now I will explain to you about all of your concepts. Now
Yeah.
you have the diabetes, and then you are now on the metformin and also the insulin. So there are the side effects on your baby and also on you. For you, there are the increased risk of the blood pressure, protein in the urine, and also black clot formations. Uh, During the labor, you may also have the prolonged labors, and also there will be the traumatic labor. Also, there is also increased risk of the cesarean section. Now, for your baby, now your baby in also decreased blood sugar level, and then also there will be the and also the also than the due date, and also injury during the delivery. Now, I have already had your ultrasound report. Now, I will explain to you about that. According to your ultrasound report, the waters around your baby is okay, and also blood supply to your baby is also okay. And
Okay.
then that is your baby is in the head down position. It is the normal position. But your baby is a little bit bigger than the normal size. And that is 4.2 kg. I need to consult from now onward. You will be taken with a group of the expertise, including my consultant, baby doctor, your diabetes doctors, as well as your GP, and also your also the pain doctor. Now, do you have any question, Anita?
Doctor, I'm just worried about the weight of the baby. Whether because my first delivery was a normal delivery, can I have natural birth this time also?
Okay, for your delivery plan, I will make the appointment to meet with my consultant. And also now I need to refer you to the pain doctor for your pain control during the delivery, because your baby bed weight is now the 4.2 kg. There will be the high risk for you for the normal delivery, but you need to discuss with by my consultant, because
Okay.
during the normal delivery, there is the risk of the prolonged labor, and also there is the risk of the baby is sick after delivery of the head, and also there is the injury to your down below, as well as injury to your baby. These are the risks of the normal delivery. But for your bed plan, I will make the appointment to meet with my consultant. It is okay, Anita?
Yeah, doctor, that's fine. That's fine. But I would like to keep as natural as possible. That will be better. And I just want to know whether my baby will also have diabetes, doctor.
For your baby to have the diabetes, baby doctor will check after delivery of the baby. Mostly, the baby delivered from the diabetes mother has a low blood sugar level, and then but baby doctor will check your baby, and then I will also make the appointment to meet with the baby doctor, so that you can discuss with him about this. Okay.
Yes, doctor. Yes, that's fine, doctor. And
Okay.
what about my delivery? When I'll be, should I wait for the pains to happen for the labor, or what kind of advice will you give for the delivery, doctor?
Okay. If your blood plan is the well, after consulting with my consultant, and then your blood plan is the normal delivery. During the delivery, we will strictly monitor your blood sugar levels, and also we will keep your blood sugar within the target range, and then we will monitor your vitals, your general condition, as well as your baby heart rate with a machine continuously. And then, but if there is any prolonged labor, we need to shorten it by means of the instrumented delivery. Do you have any question, Anita?
No, doctor. That's what I wanted to know about what kind of delivery will be there, what will be the risk for the baby and all. That is what I wanted to know, doctor.
Yeah, sorry.
Yeah, same. I wanted to know about the mode of delivery and any risk to the baby. I don't have any question, doctor. I don't have any question.
This is sufficient information, different, so that you can do through this, and then I will make another appointment to be with my consultant as well as with the baby doctor. Thank you, Anita.
Yes, just finish
Yes,
the
just
time.
finish the time.
On time, you have close the station. Okay, exactly 10 minutes, the station is closed. Okay, your station was good, this particular station, but you know, diabetes is a very vast topic. It's a big topic. Okay, so I'll put at certain places, I'll put this task at a borderline level. Now let us go into details one by one. Information gathering was quite good. Information template, you have covered everything, but there was little duplication, I think, about allergy, and I'm not sure, but there was little duplication of one of the question. That is what I noticed. Second thing is that you ask about the control and all. It's always better to ask for the HbA1c. Most of the people do know about this particular test, a special glucose test or the special type of hemoglobin test. That is very, very important because it gives the long-term control. So have you been monitored with sugar as well as special? And she's having since last 3 years. That means it will be there. Then was this a pregnancy, planned pregnancy, or was it a accidental or unplanned pregnancy? Okay, so these particular questions. Then now the main focus of the task was about the macrosomia. Okay, here you need to mainly come to the ultrasound report and start discussing about the ultrasound report, then about the problems because of macrosomia. Okay, that you have done it. You mentioned also what will be the risk and all, but with respect to macrosomia, what is, there is a little echo actually. Are you able to hear the echoing?
Yes.
Yeah, yeah. See, in this particular case, if the expected birth weight is more than 4.5, then she will go directly for cesarean section. Okay, at 4.2, because she is a case of previous vaginal delivery, it is a consultant's decision and mutually shared decision. Okay, so the option will be discussed in presence of consultant, and we can formulate whether to give you the vaginal trial or the cesarean section. However, when the birth weight is more than 4.5 kg, we directly recommend the cesarean section. In your case, both options are open. Okay. However, in vaginal delivery, the chances of two things. One, about the anal sphincter injury, and second, about the shoulder dystocia. These two things we have to talk. Then increased chances of cesarean section because of what you can say, the prolonged labor, dystocia, and all those things will lead to increased chances of cesarean section. Post delivery, the baby sugars we need to monitor. Okay, baby is likely to have jaundice. The breastfeeding is not contraindicated, so you can breastfeed the baby, and will suggest you appropriate contraception. We'll also suggest you certain test at around no, this case will not require because she is not a case of GDM, but we'll have repeat sugars soon, and we might have to adjust your dose of insulin because post delivery the requirement goes down. So we have to reassess the sugars and then come to a rescheduled dose. Okay, so these were the certain points. That is why I'll say here applied clinical knowledge and communication with the patient. Both parts will be borderline, because you should start with the ultrasound report, 36.4 weeks, and she is having 4.2, which is on a higher side at this particular stage, and still you have time, maybe around 8 to 10 days. By that time, we expect it may cross 4.5 also, which becomes an indication for cesarean section. You got it? So those couple of points, in one particular task, they are expecting you to talk on certain things. So just catch those points. Okay. But this information gathering was quite good, doctor. Now let us see about the keys of this particular task. Okay. So information gathering, the type, duration, complications, yes, and other retinopathy, nephropathy, neuropathy, these particular things were missed. Okay. Antenatal control, HbA1c, early pregnancy, late pregnancy, home glucose records, you need to ask this. Okay. Then antenatal complications like hypertension, preeclampsia, ask about current symptoms, polyuria, polydipsia, hypoglycemia, etc. Clarify previous obstetric history, birth weight, mode of delivery, shoulder dystocia, check for current pregnancy risk, use vaginal bleeding, signs of preeclampsia. Okay. Then coming to the patient safety, we have to mention that this is a macrosomic baby, the birth weight. We will discuss those sentences also. Macrosomia increases the risk of shoulder dystocia, birth trauma, brachial plexus injury, clavicle fracture, emergency cesarean section, stillbirth if poor glycemic control or post-pregnancy. Then diabetes specific neonatal risk will be hypoglycemia immediately after the birth, polycythemia, jaundice, respiratory distress. And regarding the delivery, it will be planned between 37 to 38.6 for a well-controlled pre-existing diabetes, and it may be earlier if there are any complications. So this timing they were expecting. She was again and again asking. One was about the mode of delivery, and second was about the timing of the delivery. And it was expected to talk on shoulder dystocia, birth trauma, and chances of cesarean section. Okay. So, and one more thing, doctor. Hello. Are you are you getting? Are you getting?
Yes.
Yeah. One more thing you mentioned, no, the baby can die. So you don't say that particular sentence. The baby can succumb also. There can be threat to the life of the baby also. Okay. Don't say the baby can die. I'm not scaring you. No doubt you add that particular sentence, but death sometimes, that particular word appears little harsh to listen. Are you getting what I mean to say?
So, how can I say, sir?
Yeah,
Baby
you can
can
say baby can succumb. Baby can succumb. Succumb.
suckle.
Succumb. Or you can simplify also, no problem. Let us see. We will have some things in the our slides also. We'll discuss that. Okay.
Okay.
Or you can say there is a risk to the life of the baby also. I'm not scaring. So rather than death, we can say there is a risk to the life of the baby. Okay. That way you can conclude. Okay. Then communication. See, now let's see about this communication with the patient. Our wording should be very simple. Your baby is measuring bigger than average for this stage of pregnancy, which we call it as a macrosomia. This can happen with diabetes. A bigger baby can make labor more difficult and slightly increase the chances of needing cesarean section. Then we will discuss induction of labor versus cesarean section, risk and benefits. Expected fetal weight more than 4.5. Here it is 4.2 at 36 weeks. So it may become 4.3 also. We do not know. Then consider planned cesarean section. Discuss timing. We usually recommend delivery around 38 weeks for the women with diabetes to reduce the risk of stillbirth and complications. Neonatal care, your baby will have blood sugar checked after the birth, and the team will support with early feeding. Then encourage maternal involvement and address concerns. Okay. Communication with the colleague, escalate case in antenatal MDT, inform diabetes team for insulin adjustment before planned induction cesarean section, after labor ward staff about the shoulder dystocia and neonatal hypoglycemia, you need to alert and arrange senior obstetric presence for the delivery. Okay. Applied clinical knowledge. Macrosomia in diabetes caused by the fetal hyperinsulinemia from the maternal hyperglycemia. Risks are higher if HbA1c is more than 6.5. Guideline references. These are the guideline references. Okay. So this we have already discussed. And this, never forget adjusting the insulin dose after the delivery. Okay. And breastfeeding is not contraindicated. Okay. So these were the couple of things. Okay. So we finished 4 tasks up till now total. Yesterday 1 and today 3. The last task we will take. Any query here? Should we go ahead with the last task?
Okay, sir.
Yeah. Your time starts now. Time is up, doctor.
Hello. I'm one of the doctors in the clinic today. May I confirm your name, please?
Doctor, I'm Sarah Michel, 32 years, doctor.
It is okay if I call you Sarah.
Yes, doctor, you can call me Sarah.
Okay, Sarah. I understand that you are here today because you are now pregnant, and then you have already done the sample test to discuss about this. Am I right?
Yes, doctor. Yes, yes.
Okay, Sarah. Could you tell me, before we go to our discussions, I would like to ask you a few more questions to know more about you. It is okay?
Yes, doctor, that's fine.
Okay. According to your notes, I see that you have the three pregnancy loss. So if my questions are bring back of your unpleasant situation, please don't mind. Okay.
Yes, doctor. Yes, it is really traumatic, but you can ask doctor.
Okay. Sarah, could you tell me more about your current pregnancy?
Yeah, it just around, I think, just 2 months completed. I'm quite all right, but I'm really worried about this time whether I'll be able to carry my pregnancy till 9 months or not because of my previous 3 miscarriages, doctor. There used to be around 2 months, and we used to have the scan, and then the doctor used to say that the heartbeat is not there and all. And then certain tests were carried out, and I was told that there are some antibodies, some sticky blood is there. Then there can be clots in my body and all. And I'm really worried about this pregnancy, doctor. Can you please tell me about it, doctor?
Okay, I will explain to you all of your concern. So I'm so sorry about your condition. So recovery about these events. Okay,
Voice. Repeat it again.
how
I
about your
couldn't.
recovery? How about your recovery about these events?
Yeah. Recovery was good, doctor. Recovery was good.
Okay, so do you have any other medical problem like
No, doctor. No other problem, doctor.
okay, do you have any history of black clot formations?
No.
Do you have any previous surgery on your tummy or the down below?
No.
Okay, have you already taken the folic acid now?
Yes, doctor. I'm taking folic acid.
Okay, do you have any leg pain or leg swelling?
No, doctor.
See?
Just hold on. No? Hold on, please. I'm getting some. Hello. Yes, doctor. We can continue.
Okay, do you have any drug allergy?
No, doctor.
Do you smoke, drink alcohol, or pardon me asking you use any recreational drug?
No, doctor.
How about your weight to height ratio?
It's 25, doctor.
Uh, blood group?
It's A positive, doctor.
Do you have any rejection for blood transfusion?
No.
Okay, then do you have any family history of blood clot formation?
No, no one in my family had blood clots, doctor.
Okay, do you have any, how about your support at home?
Yeah, my partner is very much supportive, doctor.
Okay, how about your, do you have any low mood or depressed during these 2 weeks?
No.
Okay, Sarah, thanks for sharing information. Now I will explain to you about your blood vessels, okay?
Yeah.
Okay, Sarah, before that, I would like to examine you with your permissions and also that in the presence of the chaperone, I would like to check your general condition and also your timing. It is okay?
Yeah, that's fine, doctor.
Okay, Sarah, I have already checked your name, age, and nation's number, and it is yours. According to your blood test results, you have that blood test show that you have a certain protein, what we call the antiphospholipid antibody. Both of the two tests that are tested for the 12 weeks apart. These antibodies. I will explain to you about this antibody. This antibody can cause your blood more thick and sticky, which lead to the black clot formations in the lungs and the lead. Are you following me, Sarah?
Yes, doctor. Yes, I'm getting it.
Okay, Sarah. So, explain to you about the effect of this protein on you as well as your baby. For you, you have the increased chance of the increased blood pressure, proteins in the urine, and also blood clot formations in the lungs and the lead. And also, and then for your baby, there is a risk of the early pregnancy loss, and then also the baby can grow small and also baby can deliver earlier than the due date, and then your afterbirth can separate earlier and then lead to the baby loss. Are you following me, sir?
Yes, doctor, I'm getting doctor. But then, how can I have a very good pregnancy outcome, doctor, if
Yes,
you're telling so
uh,
many?
Sarah, now I will tell you about your pregnancy journey to prevent that eventful events. So be taken with my expertise, including my consultant, blood doctor, counselor, and also the GP. GP doctor will take care of you, and then now you need to take the antenatal care at the consultant you need because you are now in the high risk pregnancy, and then also you will need the frequent antenatal visits, and then at each antenatal visit we will monitor your blood pressure as well as check your urine for the protein, and then we will offer you the booking blood test and also the Down syndrome screening. And then to decrease this risk, we will offer you the starting medication, what we call the aspirin. From the 12 weeks of your from now onwards, you need to take the aspirin, low-dose aspirin, and then we will also offer you the in the blood thinning agent, what we call the low molecular weight heparin, up to the 6 weeks after the delivery. And then you will need the we will also offer you the head to toe scan from the 18 to 20 weeks of the pregnancy, and then we will also offer you the growth scan from the 26 weeks of the pregnancy. Do you have any questions, Sarah?
No, I'm just thinking it's a big challenge for me to continue the pregnancy, doctor. And
Uh, yes, Sarah.
yes,
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 yes. Throughout your pregnancy, me and my team of the doctors are also help you and they support you out of your needs. So don't be so stressed, Sarah. We are here to help you. Okay, Sarah?
yes, doctor. Yes, yes.
Okay, if your pregnancy is straightforward and now you are in the delivery, we usually aim for the normal delivery, and then you need to deliver at the consultant unit, and then we also monitor you during the delivery when to when, and then also monitor your condition, and then your baby will also monitor with the machines continually, and then after the delivery, we encourage you early mobilization, and also you need to stop your blood thinning agent 24 hours before the delivery. And then we need to restart our blood thinning agent after the delivery, and then up to the 6 weeks after after the delivery. And then we will discuss about the contraception, but you need to avoid the combined pain because it will increase your blood clot formation. You have any other questions, Sarah?
Doctor, is it mandatory to take those injections, blood thinner injections, doctor?
Sorry.
Blood thinner injections, you said, no, aspirin tablet and blood thinner injections. So I'll have to take throughout the pregnancy till 9 months, doctor?
Yes, Sarah. To prevent that condition, we need to offer you the injection and the aspirin.
Can't we skip the injection, doctor? Can I have tablets only, doctor?
Uh, to tell you that I'm not. It is not best for you to take the tablet because injection is the best for you.
Okay, doctor. Okay, okay, okay.
Okay, so this is a patient information leaflet so that you can look through this, and then I will also make another appointment to meet with my consultant. So
Yeah,
thank you, Sarah.
yeah, yeah. Your time is just over now. Yes. Yeah, this was a good task, very good task. And you have covered most of the things from the antiphospholipid antibody syndrome. Okay. So here in the suggestion, information gathering was quite good. And the support which you showed to the role player was quite good, because when role player said that she's worried about the baby, whether she'll be able to continue for 9 months or not. You said we are with you, and we are here to support you. So those sentences are very, very important, and especially they are asking that only. Second thing is that regarding this another question, doctor, is it mandatory to take the injection? Then you have to be very firm. This particular condition, what we call it as antiphospholipid antibody syndrome, this mentions about the aspirin tablet as well as these injections. If this is not followed, then the chance of having a good outcome is hardly 10%. But with this particular thing, it is more than 70%. The outcome is quite good. Okay. So that particular, it was just to check the applied knowledge, how you deal with it. Okay. So if you do not take the injection, the outcome is not good. Okay. It is hardly 10% patients will have a good outcome. Okay.
Okay, sir.
Was the only thing which was expected. Rest of the template information gathering, patient safety points were quite good. So we'll just go through the key points in this particular task. Okay.
Okay, sir.
So information gathering, the number, gestational age, and details of miscarriages, any late pregnancy loss or preterm births, history of thrombosis or clotting problems that you have asked. Then autoimmune symptoms you can add. This was not asked, the rash, joint pain, etc. But you can add it. Okay. Then medication
Okay.
history, allergies, you have covered this. Then current pregnancy progress and symptoms you have asked. Family history of clotting disorders, that definitely you have asked. Understanding of diagnosis so far. Early referral to maternal medicine clinic, MDT involvement with obstetrician, hematologist, midwife, initial aspirin along with heparin. Okay. Then monitor the blood pressure, urine protein, fetal growth throughout the pregnancy. Explain importance of medication compliance. Arrange early dating scan and regular growth scan. So this you have covered. Okay. Then how will you communicate with the patient regarding antiphospholipid antibody syndrome? You have certain proteins in your blood called as antibodies that make your blood more likely to clot. In pregnancy, these small clots can block the blood supply to the developing pregnancy, which may cause miscarriage. Then you need to reassurance. The good news is that we can significantly improve the chances of healthy pregnancy by using daily blood thinning medicine and aspirin. So this is the way you should convince. Okay. We have the treatment for this, and you can have a healthy pregnancy by using this. Okay. The management plan is low dose aspirin, daily LMWH, and extra monitoring with scans, care in specialist clinic. Slightly increased bleeding risk, injection site bruising, need for hospital planning around the delivery. With treatment, 70 to 80% chance of healthy live birth. Okay. Communication with the colleague. You have to summarize the diagnosis in the notes to MDT. Please plan shared care with hematology, rheumatology. Inform GP, midwife for ongoing support, and clear written plan for low molecular weight heparin dosing, stop timing before delivery, and postpartum thromboprophylaxis. Okay. Then applied clinical knowledge. This is nothing but the definition for this particular thing. In lupus anticoagulant, 2 tests are required at the interval of 12 hours. The treatment we have already discussed. Okay. So template sentences to explain antiphospholipid antibodies in a simple language. Okay, how will you explain this antiphospholipid antibody? Your immune system makes certain antibodies that increase the risk of blood clots. In pregnancy, these clots can reduce the blood supply to the baby. This condition has been the likely cause of previous miscarriages. The good news is that we have effective treatment that greatly improve your chances. Then template reassurance sentences. Many women with this condition go on to have a healthy pregnancy and treated early and monitored closely. So these are the positive sentences which you should keep. Okay. Many women with this condition go on to have a healthy pregnancies when they are treated early and monitored early. You have done nothing to cause this. If the role player says no more, you have done nothing to cause this. This is not your fault. Then we will work as a team with the specialist to give you the best possible care. You will have extra scans and checkups to keep a close watch on your baby's growth and well-being. Okay. So that finishes the today's all stations. Okay. So this antiphospholipid antibody was also quite good.